Friends, in previous videos, we had discussed about basic concepts, pathogenesis, and classification of hypertensive disorders of pregnancy. In today's presentation, we will be discussing about clinical part.
So what are the symptoms? How does patient present to you? Headache, visual symptoms, epigastric and right abdominal pain. Many times when you present your case in the exam, so what you do is patient has presented to you this on this thing we have measured blood pressure and patient is hypertensive. You have to give a negative history also because you have to ask about headache. You have to probe the patient, and many times patient does not take these things very seriously. You have to ask them about the history of headache, visual symptoms, epigastric or right abdominal pain, because patient can have 10 reasons for abdominal or epigastric pain. They may not take it serious, but you have to understand this and ask this. So this is important, what examiner is interested in finding out from you, that what are the symptoms of preeclampsia. Now, what are the signs? Patient can have hypertension, non-dependent edema. Patient can have brisk reflexes, ankle glowiness more than 3 beats, and fundal height may be decreased because of IUGR. So, which are the patients which require, you have to suspect that this patient is going to develop PIH. Younger patients, less than 18 years of age, primary gravida, obesity, multiple pregnancy, new paternity, patient is getting pregnant from another partner. Racial genetic factor. Socioeconomic status. History of chronic hypertension. PET may appear before 20 weeks in H-mole, acute polyhydramnios, and multiple pregnancies. These are all these things they have been explained. Now, pregnancy-related factors, we have multiple gestation, unexplained FGR, gestational hypertension, hydrops or hydropic degeneration of placenta. Now, how do we predict preeclampsia? One thing which has come up is a HDP, gestosis score. This is important. This involves all the existing and emerging risk factors in the pregnant women. Score 1, 2, and 3 is allotted to each clinical risk factor as per its severity in development of preeclampsia. I'll show you this chart. So this is a risk factor. So there we scored 1, 2, 3, 1, 2, 1, 2, 2, 3, 3, 3, 3, right? When the total score is more than 3, pregnant women should be marked as at risk for preeclampsia. This is one thing which we again got asked in exam. What is HDP, gestosis score? So these are the risk factors. You may not remember these risk factors, but you can always tell them there is a list of risk factors which have been scored 1, 2, and 3. If total of these, any of the risk factor which is present is more than 3, so these patients are at risk of preeclampsia. Now, how do we predict? This is initially we were doing rollover test. We were doing lateral to supine pressure. If there is a increase of diastolic blood pressure more than 20 millimeters, this was we doing earlier. Angiotensin, these are theoretical things. So mean arterial pressure, if it is more than 90 millimeters mercury in second trimester, these patients are liable to develop PIH. And if there is a persistent of diastolic notch at 18 to 24 weeks, this is what we do on Doppler study. This is again question which is asked. So prediction of preeclampsia can be from maternal factors, which I told you the gestosis score. Then there can be markers and there can be Doppler findings. Combined factors, maternal risk factors, measurement of MAP, mean arterial pressure, serum placental growth factor or PIGF, and uterine artery pulsatility index, or we call as PI. Now, there are the combination of maternal risk factors, blood pressure, and uterine Doppler can detect just over 75% of women who will develop preterm preeclampsia. Addition of placental growth factor improves detection to 80%. But you need not get these markers get done, or another thing which has come is a PAP-A, right? You again don't get a PAP-A done especially to find out the prediction or to predict PIH. If you have done it as part of your routine first trimester screening, then it helps you. Otherwise, just to diagnose or just to predict PIH, PAP-A is not required. All right. Now, these are the maternal risk factors. These are available in the books. There are high risk factors, any one, or moderate risk factors, two or more. They can be prior to pregnancy, demographics, depending on the patient's weight, pre-existing medical condition, and what happens in this pregnancy. These are the maternal factors. And then the biomarkers. One is the placental growth factor. It is decreased. SLFT is increased, and soluble endoglin is increased. These two are increased. This is decreased. All right. Then we have inflammation. We have necrosis factors. All this. But once you write in the exam, you can mention these things. But what they are interested in is only this particular thing, that these things are required, and maybe a PAP-A. And maybe a PAP-A, right? These things are required as a biomarker. Now, what are the Doppler findings? Doppler is, we know that this is a SD, means this is a systolic, this is diastolic wave. S by D is SD ratio. S minus D divided by S gives us resistance index. S minus D divided by P mean is pulsatility index. So most of the times PI is the important story which we measure. Now how do we do it? This is a uterine artery. This is uterine artery Doppler. So what do? We obtain a sagittal section of the uterus and cervix at the cervical level, and then we turn our probe so that the vessel comes, and the gate has to be smaller. It has to be two, and then your, the angle of insonation should be less than 30 degrees. As close to 0 is better, but it should be always less than 30. And the sampling gauge should be 2 millimeter to cover the whole vessel, right? Take 3 measurements and then take this thing, right? So this is the gate, right? We are measuring. So this is S systolic peak. This is end-diastolic velocity. This is what we call as, this is a notch. All right. In non-pregnant uterus, this notch is present. In normal uterine, this is normal, right? In first trimester also, this is normal. There is a presence of, we call this as a diastolic notch, right? In second trimester, that notch goes away. All right. So this notch, which was present here, is not present here in second trimester. All right. And even third trimester, it is not there. If it exists during second and third trimester, this patient is a high risk factor for, you can say that this patient is going to have a PIH tomorrow. All right. That is one part. A second part is your PI, PI is important. We have nomograms which are available for PI at different gestations. So now take this. Now this is normal and this is not, right? Now see, the third trimester, this should be like this, right? But if it is like this is abnormal. This is in third trimester. All right. Now what is PI in second trimester is 0.8 to 1.2. All right. In third trimester, it is 0.6 to 0.8. If it is abnormal, it is 2.45, right? Now, another thing which has come up is a diastolic notch, right? Now, some people have measured even the index, with what we call as notch NDI, depth of notch index, right? What do they is they take this as A is as A, and this is B. So A divided by B is taken as NDI. So what is NDI? NDI is equal to A divided by B is NDI. Now, what is the importance and what are the values? Diastolic notch is if it is absent. C for PI, is it less than 1.0? This is a low risk patient. Diastolic notch is present. See the PI, if it is it less more than 1.7, measure the depth. All right. Now, how do is depth? PI more than 1.7 plus NDI more than 0.55 is a high risk subject. Also, PI less than 1 and absent, diastolic notch is a low risk subject. Right. So what is the importance? If we find any of these things like PI even in one of the uterine arteries more than 1.7 and or NDI is more than 5.5, even in one of the arteries, please start aspirin. This is only what you can do. So now coming back to the basics. So you have to start them before the second wave occurs. That means 12 to 16 weeks. If you start at any case, it has to be started, say, before 16 weeks if you want to prevent PIH. Anything after 16 weeks, when everything has happened, aspirin is not going to be effective. Okay? Now, how can we stop aspirin? Yes, they say if PI is dropped by half or more, or if not disappears, you can still stop aspirin. So what is the dose? In India, it is 75 milligram what is recommended. In ACOG recommends 85, 81, WHO 75, RCOG gives 150. All right. So what are the detection rates for screening methods? If maternal only, MAP only, 76%. If combined, like all 4 tests are given, detection rate for early onset is 75 and late onset is 47. Mini combined, what they do is basically they do maternal factors, MAP, PI, and PIGF. They do not include PAPA. They say if it is like this, then contingent is you do all these things. If you find that these are at high risk, then you can do PIGF and other things as a second stage test. This is a 2-stage test, right? So this is what one is aspirin, which how can we prevent? Second, which has been proven is to be of some value is high dose of calcium, more than 2 grams per day. Aspirin, fish oil, maybe antioxidants, but nothing much has come up. Only aspirin is, and calcium and aspirin, 2 things which have been for till date proven to have some beneficial effect. Now, how do we manage it? Termination of pregnancy at appropriate time, only curative treatment, birth of alive and healthy baby, complete restoration of health of mother. Maternal assessment, how do we assess mother now? Which are the patients who are going to have adverse maternal outcome? So patient comes to you, now how will you say that this patient is going to have trouble tomorrow or going to have adverse? So there is another model they have come up with, what we call as full Pyers model. It predicts adverse maternal outcomes in hypertensive pregnancy and preeclampsia specifically when performed at least twice weekly. Okay, it should include blood pressure, proteinuria, and this is it is done for predicting adverse maternal outcomes following the diagnosis of preeclampsia within 48 hours after admission to the hospital. This tool helps to determine the maternal risk in settings of preeclampsia. So what we do is there is a calculator wherein what you do is you put your weeks here, gestational age and SpO2 value, platelet value, creatinine value, and liver enzyme value. It will give you probability of adverse maternal outcomes. You can calculate, this is online available. You can put these things. A threshold of more than 30% as a threshold to rule in the outcome. All right. If it is, say, it comes to say 40% here, then this means this patient is going to have a trouble tomorrow. More chances, right? Another model which has come up is a mini Pyers. Now, in this particular thing, you needed all these things, platelets, creatinine, AST. But here they say only systolic blood pressure, dipstick proteinuria, parity, gestational age, and symptoms. So this is a mini Pyers model which is available. Here we put weeks, days, any previous deliveries, this, multipara or primary, chest pain, headache. We don't need investigations in this except for a dipstick test. Even this calculates. This also helps in those areas where we do not have resources for full investigations. So what investigations do you do, ma'am? Urine routine investigations, then you routine, then screen blood sugar, VDR, whatever, all these things. Obstetric ultrasound is done. Specific investigations which you do is complete hemogram, general blood picture, platelet count, 24-hour urine protein, liver function test, kidney function test, serum uric acid, coagulation profile, fundus examination, Doppler ultrasonography, and angiogenic biomarkers if possible. All right. Now, biochemical parameters values in pregnancy and preeclampsia. In normal, say we have all these things. Bilirubin is less than 1, it had more. Here it is, your alkaline, say SGOT, SGPT are increased more than double. If they're more than 2 times, then they're important, right? And creatinine is more than 1 milligram. Okay. Now, how do we manage for early detection, increase antenatal visits, especially third trimester? Blood pressure more than 140/90 to be admitted to the hospital for evaluation of severity. Mild disease may often manage as outpatient. Hospitalization when to do? If there is persistent or worsening of hypertension or patient develops proteinuria. Care to be taken is the patient has to be, slightly, there has to be reduced activity. Absolute bed rest is not necessary. Adequate protein and calories should be given. Sodium and fluid intake should be adequate. Salt restriction as such has not been proven to be, very advantageous. So do not give diuretics to correct oliguria because this causes trouble. Do not give diazepam to stop emulsion. This causes apnea and aspiration at times. Now, maternal surveillance in mild preeclampsia, what do you do is, this is again question which is asked in exam. Mild patient comes to you, what do you do? Maybe to begin with, measure BP 4 times per day, measure body weight weekly, daily urine evaluation. Now, this is in PIH. What we told earlier was in gestational hypertension only, where we were monitoring it every weekly. Here it is slightly more important, more frequently. Proteinuria in a 24-hour specimen every week again. CBC platelet count twice per week, and inquire about decreased movements, development of scotomata, headache, epigastric pain. You have to monitor, right? Daily fetal heart rate monitoring, daily fetal movement count, modified biophysical profile every week, fetal biometry every 3 weeks. This is again we ask, how frequently do you get your ultrasound done? We measure fetal biometry every 3 weeks, because anything less than 3 weeks, your fetal biometry does not give you much information in terms of diagnosing as a growth retardation. So minimum time has to be 3 weeks to get a biometry evaluations for diagnosing FGR. All right. Now, umbilical and cerebral Doppler every week is to be done. So what do we do is BPP every week, Doppler every week, ultrasound every 3 weeks. All right. So baseline, we discussed. NICE guidelines recommend 2 weekly Doppler. Here we were say every week. NICE says every 2 weeks in mild PIH. In mild PIH, if it's severe, you can increase the frequency. Daily heart, this is we. So amniotic fluid volume again twice every week. See, I just want to emphasize another thing is amniotic fluid volume is very important again, where you do not have facilities for Doppler, everything. You can measure amniotic fluid volume and biometry, say every 3 weeks, right? And that helps you. Initial recommended management of severe PIH, immediate hospitalization, detailed history taken to assess severity, headache, all these things, detailed examination for edema, brisk reflexes, clonus, chest auscultation, IV magnesium sulfate started to prevent convulsions. This is for severe PIH, all right? Antihypertensive medication administered to lower blood pressure. So what we do is monitor these patients, monitor, do prevent convulsions, give antihypertensives. The target should be between 140 to 155 or 150, and diastole should be around 90 to 100. Should not suddenly decrease or very fastly decrease blood pressure. Corticosteroids given between 26 to 30 weeks gestation. How do we decide about delivery? Gestational hypertension, you can take this pregnancy to term. Mild preeclampsia, 37 weeks. Severe preeclampsia, 34 weeks. Eclampsia should be delivered once mother is stabilized after giving magnesium sulfate. Depending on the gestation and the Bishop score, you can think of delivering by cesarean or labor induction, whatever is possible, right? Now time. Now, indications for delivery in a preeclampsia are if we have abnormal neurological features, one, or if there is a repeated episodes of severe hypertension, if there is pulmonary edema, progressive thrombocytopenia, transfusion of any blood products if patient requires, abnormal and rising creatinine levels, abnormal rising liver levels, liver enzymes, hepatic dysfunction, abruption with evidence of maternal or fetal compromise, non-assuring fetal status, including death, urine output is less than 400 ml, or if there's a persistent severe epigastric pain, which probably is giving information about HELLP syndrome or some liver problem. There's a general agreement that all patients should be delivered if the disease develops after 34 weeks gestation. Prompt delivery is indicated if there's a imminent eclampsia, multi-organ dysfunction, severe IUGR, less than 5th percentile, suspected abruption placentae, non-irregular fetal heart. We have to immediately deliver. Some consider delivery as a definitive treatment regardless of gestational age in severe PIH before 34 weeks. Other recommend prolonging pregnancy for fetal lung maturity till 34 weeks. All right.